Thank you all the participants for your kind words and compliments for the last session. Today we'll be discussing another topic. As I said in the beginning, these are all, nothing is new for all of you. We have learned all these topics during your undergraduate medical education. But this will be a refresher or going back to the basics and just go through the basics and how we can manage on our own in the field. So today we'll be discussing on asthma and COPD, which we know that we all come across very, very commonly in day-to-day practice, even in a normal primary care setting as well as in a palliative care setting. So today we have Dr. Anupama as our faculty. She's a pulmonologist working in PhD Medical College, Coimbatore. She's also trained in palliative care, foundation course in palliative care, and she's taken up the virtual mentorship program and everything. So she is one person who can connect the respiratory issues that we face in the field or in the OPD with the palliative care aspect. So she's trained in both. So I'm so glad that she agreed to be part of this program. She is doing a conference right now, and in between that, she took out her time to be with us and to share her knowledge. Thank you so much, Dr. Anupama, for helping us with this. And most of these people, some of them are maybe familiar to you. All of them are working in palliative care, or people who are trained in palliative care, or people who are there to refresh their basics back. Thank you, Dr. Anupama. Over to you.
So good evening, everyone. Good evening, everyone. Sorry for the delay, actually. Some connectivity issues I was having. And basically, I'm feeling a little nervous today, presenting in front of stalwarts like Dr. Raja Mayer and Dr. Sridevi. But still, let me see how much justice I'll be able to do to this topic. So anyway, I bring you greetings from PSG Hospitals, Coimbatore. I'm a professor of respiratory medicine in PSG Hospitals last 12 years. So next slide, please. I can just manage from here. Yeah. So what are the objectives of today's session? Basically, to understand the role of palliative care in the advanced lung diseases. To identify the common problems for people in their final year of life with the end-stage respiratory diseases. And to understand the medical and physiotherapy management and treatment in the last year of life for people with end-stage respiratory diseases. So before going on to the topic per se, I would like to just tell you actually one thing. See, we all actually are aware, and I know most of you are actually postgraduates in different fields and also practicing specialists, as well as palliative care specialists. So one thing is there, I'm also a geriatrician in addition being a pulmonologist. So one thing is there, like most of the times we know actually that in the brainstem, the respiratory center is there and the respiratory center gets triggered by various receptors like mechanoreceptors, stretch receptors, and from the diaphragm and also from the intercostal muscles. But as you see, actually, these are the ones which are going to actually, if any of this process gets interrupted, we get the ventilation perfusion mismatch or ventilatory demand increases. And that is the time when actually breathlessness is obvious. So why it happens so in elderly? So, you know, aging. Now the aging part, if you're going to see, there's this one in aging and lung health. See, there's a progressive reduction of chest wall compliance and there's a reduction in the strength of respiratory muscles. There's also a change in both lung parenchyma as well as the peripheral airways. Even the shape of the thorax, if you see, because of the kyphosis as well as because of the osteoporosis, the total number of degenerative changes occur in both the intercostal, intervertebral and costovertebral joints. There's a decrease in both peak inspiratory flow, peak expiratory flow, as well as forced vital capacity, and thereby it affects the efficiency of gas exchange. There's loss of elastin, which increases the residual volume, and the dead space, which decreases both the elastic recoil. It causes both airflow limitation and air trapping. So, and there's a very poor sensitivity to the chemoreceptor function. So, you know, hypoxia, hypocapnia are such important drives. And these are the ones actually which will help us for the proper ventilation preventing the ventilation perfusion mismatches. But in the elderly, what happens, even the perception, because we ourselves get surprised when they walk into the OP and their hypoxia is so severe, they are with 85, 80, and they have not even known that they are having breathlessness. So impairment of microbial defense mechanism, of course, this is less, there's a mucociliary clearance is very low effective. So chance of aspiration is very high. And thereby the elderly are the ones who are getting more prone to various infections, especially if they have a lung disorders, all the more. Yeah, next. So before going on to this one per se, so just briefly on palliative care. So we are all aware of it, most of us. It's exactly what the term means. It's from a Latin term known as to cloak. So palliative care is a multidisciplinary approach and specialized medical care for people with serious illnesses. The goal of the therapy is basically to improve the quality of life. So this is very important for most of the physicians and pulmonologists and geriatricians, everyone, because most of us think that the end of the treatment is after giving him the best treatment. I have optimized the treatment, but you always see a sorrow look on the face of not only the patient, but also the caregivers. And they just look, oh, this is it. Now, what is it? Because I'm still having breathlessness and I'm not still able to walk. I'm not able to do my regular ADLs. So how do you count for these all things? And the busy physician is usually not having time for those things. So we write a prescription and we hand over and we are done with it. So this is where actually the palliative care is going to step in. So it is focused on providing the patients with relief from symptoms, pain, physical stress, mental stress of any serious illnesses. And a WHO statement has described palliative care as an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, not only in the medical, but physical, psychosocial, and spiritual problems. Yeah, next. So issues which are addressed in palliative care will be physical symptoms such as pain, fatigue, breathlessness, loss of appetite, nausea, vomiting, shortness of breath, and insomnia, which can be relieved by medicines and also by other methods which are non-pharmacological, which I'll be telling you in detail. Emotional and coping, like sometimes actually patient along with any chronic disease, whether it's a lung disease, whether it's a cardiac, whether it's a renal or a liver or a congestive cardiac, whatever. See, depression, anxiety, fear, panic are the ones which are actually not addressed by most of the physicians. And that is the one actually where palliative care steps in. Experts may provide counseling, recommend support groups, hold family meetings, or make referrals to mental health professionals. Yeah, next. So practical, see, many a times actually you often say that, yes, you arrange for home oxygen, you also arrange for BiPAP, you also arrange for a home caretaker, and 24 hours, better to have a caretaker. And if needed, BiPAP or maybe NIV also. So, the cost of these therapies. So the patient and the caregiver are the ones who are going to actually really calculate. So per day, it is 400 rupees a BiPAP, and per month, it is 5,000 rupees a oxygen. And also a caretaker costs in most of the cities, at least in our place, per day 1,000 rupees. So that itself works up to 45 to 50,000. So patients may have financial and legal worries, which are no way concerned for us, and which should be exactly employment concerns, his family backup, who is the person actually who is going to pay for all these, and concerns about completing the advanced directives. So even there's a stage in India wherein it's difficult to buy an inhaler, which is worth 450 to 500. I myself have seen, and most of the patients, madam, you are writing a new one. How much I'll have to purchase? Like, what will be the cost for me per month treatment? For many patients and families, the technical language and specific details of laws and forms are hard to understand. And what about the spiritual part? Spiritual part, they have, it's our country, especially actually, they have got multiple beliefs and values. So you definitely need to address these also, in addition actually to the medical management. Yeah, next. So let us actually see what are these advanced lung diseases. See, in this field actually today, almost I have completed 25 years. So my post-graduation was in 1997. Okay, so I have graduated from Armed Forces Medical College, Pune. It was a 450 bedded hospital, and we had seen all sorts of lung diseases during our time. And those were the time, you can understand, when HIV had come newly, and it was diagnosed in 1993, 94. Yeah, and MDR tuberculosis, and also many lung diseases. So when I was a fresher, when I came out, so I thought the treatment ends at just the medical management. I diagnosed asthma, I diagnosed COPD, I diagnosed ILD. But today, after spending 20, 25 years in this field, we know that the disease, chronic lung diseases are the main things which are very difficult to manage. It's not one-time prescription at all. The patient is going to be with us for nearly 8 to 10 years or maybe 15 years. And this is the time where he lands up in various exacerbations, which may amounting to respiratory failures and also chronic on long-term oxygen therapy. These are the challenges actually. So actually, I came to understand maybe with experience, because those were the days when we did not have all these courses, especially online was a remote possibility. So, sorry, types of advanced lung diseases. So we have obstructive lung disorders, and these are commonly the COPD, asthma, and the emphysema. Then restrictive lung diseases, wherein air cannot get in. See, air cannot go out is most of the type 2 failures. Type 1 failures are ILDs, sarcoid, idiopathic lung fibrosis. You have interstitial pneumonias, and it could be drug-induced also, radiation-induced also, and many others. Similarly, neuromuscular disorders, like we have got myasthenia gravis and neuromuscular disorders, and thoracic extrathoracic. So many patients are there who have got a congenital kyphoscoliosis. But as I told you, the first slide itself is lung aging. So as they age, actually, their problems further multiply. And many times I see in the people with mid 30s and 40s, they come back to us with multiple problems. Next. So what are the current statistics actually for these chronic lung diseases? So India has nearly 18% of the world's population and 32% of the DALYs, like disability adjusted life years, from chronic respiratory diseases. So that's a huge amount. And similarly, India has 1/3 of the global burden of chronic respiratory diseases. And DALYs from the COPD itself is 1.7 times higher than the world, and worsened by the aging population. And estimated rise of 60-year-olds. See, today actually the cutoff is 60-year-old, they are saying. Earlier it was a cutoff of 65 for geriatrics, and they used to classify 65 to 75, newly old, and very old, 75 to 85. Now you just see that after 60 years, by 300% is going to raise, and 80-year-olds are going to increase by 700% in the next 30 years. So with this, obviously, the various problems that we are going to deal also are going to increase, including malignancies as well as chronic diseases. 6% of the total annual healthcare budget is because of the respiratory diseases, especially COPD, which is the topmost. Next. So if you see advanced lung diseases, what are the various clinical presentations? So the commonest feature that I see is dyspnea, breathlessness. 78% say with activity, and even 24%. So they need not even speak to us. So when we look at them itself, the way they have entered our clinic, the way they had walked, the way they are having tachypnea, the way they are using accessory muscles, the way he is looking at us and he's not able to complete a sentence without a pause in between. So that's more than enough. And there's a tremor slight in the hands. So these are the things which I need not even auscultate. So I tell my postgraduates, no need to auscultate. Just the look of the patient itself makes you know that he's having a chronic lung disease. And the first question is out, he is yes with the answer. Do you have recurrent LRTS? Yes, ma'am. Last few years he had been having. So in addition, he may be having a dry cough. Sometimes it may be productive, chest tightness. He may be having an audible wheeze. Then the family members say, no, in the night we can hear the wheeze also. And he'll have extreme fatigue and weakness. He says even ADLs, even to go to the restroom, I have to depend on somebody. Along with that, his appetite goes down. He may be having pedal edema, which may be evidence of pulmonary hypertension or cor pulmonale. Then there may be excessive respiratory mucus production. In addition to all these, he will be depressed, obviously, with his symptoms. Sometimes anxiety and panic disorder, that whether this is going to lead to his death. And insomnia and sleep disturbances are very common. And as I told, tachypnea. And they'll feel better sitting forward, and they'll have pursed breathing. And there will sometimes BMI will be very low with a lot of muscle wasting, increase in the anterior posterior chest diameter, and some use of axillary muscles, as I already told. So these are few of the clinical symptoms as well as signs actually which are going to overlap, and then you don't need much actually to really get to the diagnosis. Yeah, next. So as you see, COPD is the one actually which is the most important disease, and this is the one which has been as per the gold, like gold 2022, let's say actually. Earlier they used to say yes, cigarette smokers they are going to get, but now they have done multiple studies and they have said even the ladies who are getting COPD is because of the biomass exposure. So in fact, there are a number of studies who have been done in the rural background where you see very small kitchens, and also I ask how big is your kitchen first? Do you have any small window at least to escape the air? And do you use biomass actually for heating up water? So last 20, 30 years, most of the ladies would have done these all things. And this is the reason that we are seeing a increased amount of COPD in the ladies. Similarly, occupational exposure. So we see in foundry. So I'm in Coimbatore, so we have a lot of textile mills all around. So we see textile, this one, foundries, and also mills and silicosis, cement exposure, coal miners, found bakeries. So all these are the ones who are actually getting exposed to occupation to COPD. Similarly, indoor and outdoor pollutants, and also the increase in the pollution levels, then the irritants, and now they have come out with new thing in the gold 2022 that they are saying that even people who had recurrent LRTI in the younger age, even who have got a genetic predisposition, even who are small birth weight babies, all of them actually. So we have to ask, even in the history, I asked my PGs, low birth weight, you ask them, were they preterm babies? Were they having recurrent LRDI? So these are also have become new things now. Additions. Earlier it was only smoking and lung. No, now there are lot of multiple etiologies wherein you have to go. And of course, alpha-1 antitrypsin. Now, globally in the world, most of the people who would have gone abroad and got themselves work up and then they come with the big files, definitely alpha-1 antitrypsin would have been done. Whereas in India, very few institutes are doing the alpha-1 antitrypsin, especially in youngsters, 20, 30 years when they come with a breathing difficulty and when their father also had, definitely it mandates that you have to do alpha-1 antitrypsin. So what are the other causes of chronic airflow obstruction? This is emphysema, chronic bronchitis, and asthma in some cases. I'll just briefly give 2 slides on why asthma in some cases I've said. Yeah, next. So we all know that spirometry is the gold standard. So any obstructive airway disease, we have to go ahead to confirm the diagnosis. So, but asthma, many times we write physician diagnosis of asthma. That is also enough. So that is the gold. I mean, that is the GINA guidelines, and GINA has clearly said that even physician diagnosis. Supposing if you are in a remote facility, we are maybe working in institute, so we have all sorts of facilities. Even keep a peak flow meter with you, and you give to your patient and ask him to monitor twice daily, or that is also enough. Or if you're having some way, actually, you have to establish that, yes, gold standard being spirometry, actually, wherein you'll have a diagnosis whether it falls into COPD or is it asthma, or now we have got a new term known as asthma COPD overlap. Yeah, next. So based on spirometry itself, the classification of COPD is based on mild, moderate, severe, and very severe, wherein actually they have said that mild falls, FEV1 is the main value. So anything above 50% is mild. So post-bronchodilator FEV1 is another one actually which should be less than 70%. So that moderate is the one which is anywhere between 50 to 80%. Severe is anywhere between 30 to 50. Very severe is the one which is less than 30%. So most of our people actually are the ones who fall between severe and very severe by the time they come to us. Next. So this is another, actually, this is the ABCD assessment tool which had come by the gold guidelines. And this is actually basically not only they said why spirometry alone can't classify the severity of the COPD. So they said, okay, fine. We need to know also few more history, like how many exacerbations he had in the last 1 year, how many times each exacerbation needed hospitalization, and what is actually the CAT assessment score, COPD assessment score. And similarly, MMRC, I'm sure most of you are aware. Where does the dyspnea scale actually? So in COPD, we use MMRC. We don't use the NIHA much. So in this actually, is it 0 to 1 or is it more than 2? So they have taken various parameters in addition to spirometry into consideration now actually to classify the severity of the COPD. So, any exacerbation is nothing but amounting to the use of short course steroids or short course antibiotics on approach to a physician or a general practitioner. Or hospitalization, of course, amounting to hospital admission which needed parenteral drugs. Maybe actually he also needed a BiPAP or a non-invasive ventilator. So this is how we have classified now. So we ask our postgraduates whether it's in the A, D, or C or B. So D is the one which is considered to be the very worst. A is the one which is a milder form. B and C are the ones which will fall anywhere in between. Okay, depending on the number of hospitalizations and the exacerbations. Yeah, next. So the biggest problem actually why to manage COPD is the number of interleukins and the cytokines that are going to be released, and multiple cytokines are the ones which are responsible for the various comorbidities. So many times they come into the EMD with the exacerbation, and finally we find out that it's the ACS, acute coronary syndrome, or he has had a severe LVD, or he's the one who had a arrhythmia. Commonly we are seeing actually atrial fibrillation are very common, or he may have a peripheral vascular disease leading to pulmonary emboli or a pulmonary thromboembolism. He may be also having a hypertension and a cardiac CAD. So these are cardiovascular comorbidities are the major ones in them. And we have seen many patients of COPD actually succumb to these problems because of not identifying those and treating as a COPD exacerbation. In addition, the other systems like he'll have osteoporosis. So most of our people have to be on vitamin D supplements and calcium supplements because of lot of factors. Actually, I'll be telling you later. Anxiety and depression is very common in them. Metabolic syndrome, of course, with dyslipidemias, and OSA overlap. There's a terminology known as COPD OSA overlap. So many times they have insomnia, they don't sleep in the night, they have some snoring. Finally, we think that, okay, fine, COPD I'm treating optimally, but why the patient is not improving? Well, you have not looked into the component of the OSA. Your patient is obese, your patient has high BMI, your patient is unable to walk, he has got daytime sleepiness, he takes short naps in between, his sleep quality is very poor in the night, and his partner says that he had been snoring, and sometimes the snore is so big that he stops snoring, and they feel that he has stopped breathing. So these are the typical history actually, and then definitely you need to let go and then look into whether I'm dealing only with COPD or is it a COPD OSA overlap. Then many a times these people will have lot of purulent sputum and he won't be responding to your optimal. Then you have to just see whether he's having underlying bronchiectasis, because COPD and bronchiectasis go very much together. A CT scan shows that yes, he was having emphysema, he was having panlobular emphysema, but now he has also underlying bronchiectasis. So another common thing which is seen is GERD. This could be either because of medications, he may be having a gastroesophageal reflux disease, because of a lax esophageal sphincter, that could be because of medications, or it could be actually because he may be obese, or it could be because of OSA, or recurrent aspirations which can occur because of his COPD itself. And he may also have anemia and vitamin D deficiency. So you're not going to complete your treatment by treating just COPD. So you have to also look to the systemic manifestations of COPD. Yeah, next. Next. Yeah. So as I told you, the commonest is it's a multi-system disorder. So we always say actually to our, most of the postgraduates get their thesis this way: look into osteoporosis for COPD, look into skeletal muscle dysfunction for COPD, look into PVD in COPD. So these are the common things which we often see, and these will lead to vertebral fractures, and also the sleep apneas and sleep disorders are quite common in these. Next. Well, a little two slides on bronchial asthma, because all of you would have treated bronchial asthma and you must be wondering why ma'am is. See, bronchial asthma is a heterogeneous disease which is characterized by chronic airflow inflammation. And you all are aware actually that the patient will have the history right from younger age. He will have a family history. He will have history of atopy. He will have allergic rhinitis to start with. Slowly it will lead to actually asthma and wheeze. He may be having some allergic conjunctivitis, allergic symptoms in the form of allergic dermatitis also. And then he may be having, so a lot of trigger factors, like most of it is dust, smoke, external triggers, environmental triggers, pets, and also climate changes, seasonal, and also a lot of strong smells, sometimes some drugs, sometimes some food allergens. So this is a typical. So why actually the bronchial asthma should be considered as a chronic disease? Okay, next. This is the terminology. So we wait actually when a chronic bronchial asthma patient develops an airway remodeling leading to some epithelial changes. There's an increase in the smooth muscle mass. There's an increase in the number of fibroblasts. there's a subepithelial fibrosis, and this leads to a persistent airflow limitation. Finally, it becomes so persistent that it is not reversible. So what's the difference between COPD? COPD is partially reversible, whereas asthma is the one which is good reversibility. So this is seen on the spirometry. So we always say is how much is the reversibility? We call bronchodilator reversibility. It should be equal to or more than 12% or 200 ml. So whereas in asthma, we see that it is very good reversibility, whereas in COPD, it will be very 3%, 2%, sometimes even in negative. So typical asthmatic sometimes become a COPD case because of the long-standing, poorly treated, poor compliance to medication, poor adherence to treatment, and also various trigger factors which are persisting, leading to a chronic respiratory advanced disease resembling a COPD. So this is what makes asthma COPD. Yeah, next. So, there are three terms which we use commonly. So I ask, is it uncontrolled? Is it difficult to treat? Or is it severe asthma? So, there are various. We have got a GINA guidelines. There's a stepwise GINA management. I'm sure actually we'll be sharing some links for the GINA guidelines. You can just type GINA 2022 for bronchial asthma and you'll be getting it. So it's a stepwise management. So uncontrolled asthma is when a patient is referred to us from a general practitioner, and when I see he is on only intermittent treatment. As and when I get asthma, I take treatment. So he is not on optimal GINA guidelines stepwise management. So that is known as uncontrolled asthma because he was not put on a proper GINA stepwise management. Okay, difficult to treat is he has been put on the GINA guidelines, GINA treatment, but other problems have not been attended to. So what are the other problems? His adherence, compliance to the inhalers, whether he's taking or not. His comorbidities have not been taken care of. His trigger factors have not been taken care of. So when all these things, comorbidities, triggers, and adherence to treatment, and is the diagnosis right or not? It may not be asthma. It's a common saying, not everything wheezes is asthma. So it can be a tumor which may be sitting, it can be a foreign body, or it could be actually a simple bronchitis. So these are the things. So you have to revise your diagnosis when the patient is difficult to treat asthma. What is severe asthma then? Severe asthma is the patient has been put on the stepwise management. All comorbidities have been taken care of. Patient adherence and compliance to treatment has been taken care of. All triggers have been removed. In spite of that, he is wheezing. He's having acute exacerbations. He's having recurrent admissions. So that is severe asthma. This is a stage where we call this is a difficult phase. So uncontrolled asthma, difficult to treat, and severe asthma. These are the three different variants actually of a management of bronchial asthma. Many times there will be overlap, but we should be clear about this. Yeah, next. So what is the burden of COPD and other advanced lung diseases? So 51% report work negatively affected. Obviously, they won't be able to work. 70% experience difficulties even with regular activity. Ladies especially, they can't do their household activities. They'll have to sit at one place. Even a minor activity makes them very breathless. They'll have insomnia and they may not be social isolation. They may not be able to participate. And 46% have family activities which are affected. They are the ones which will be always left off. In fact, they are the ones who will be asking for respite care. Like there was one of the patient recently, one of the attendant, they said, can I keep her for 1 week at your place? Because we are having a family function. She may feel isolated sitting in one room. I can't bring her to attend the function. So these are the common problems which we are seeing actually. And they keep them for 1 week to 10 days in the palliative homes. Yeah, next. So what are the COPD variants? This also we have classified into mild, moderate, and severe. So mild is the one which actually the patient who walks into your clinic, you give the management, and then he goes back. Again, he comes after a month, and that is known as, okay, fine, he's mildly exacerbating. Sometimes I'll give a nebulization, and that should do with him, or sometimes he may have a nebulizer at home, and I'll tell him the rescue medications what to take. The moderate one is the one which is unstable. He exacerbates very easily. Even his grandchildren will have a minor viral infection, he gets it immediately. He'll be taken actually for a small trip, he'll get it immediately. So these are the moderate exacerbators. Then you've got the acute one. You know actually that he's very bad, he's very unstable in spite of admission. I'm not very happy. 20% I have done my bit, but 80% still. Within 3 days, they come back sometimes saying that, ma'am, discharge, he was okay. But again, within 3 days, he became bad. Next. So COPD patients usually have, of course, all of you are aware, cough, productive most of the time. Sometimes it may be dry. Wheezing is always there, chest tightness. Now, these are the patients which will have a baseline respiratory symptoms always. When COPD says, ma'am, I'm having cough, I say, yes, you'll have. When I'm having mild breathlessness, it's okay. Baseline you'll have. The day it's going to worsen, the day lot of pulmonary secretions you're bringing out, the day the color of the sputum is changing, the day your dyspnea is worsening even for minimal activities, today you're able to bathe on your own, you're able to eat on your own. The day, those are the things you immediately recognize that you are about to have exacerbation and you come to me, or you take a nebulizer at least at home, or you go to your general practitioner immediately. So these are the times. So I give them a very clear idea that don't take a chance because you are at optimal, you are at baseline. You always have. So anything small triggered, you will have an acute exacerbation. So increasing evidence base demonstrates that the overall symptomatic burden has a detrimental effect. So what are the effects on him? His health status is poor, his quality of life is poor, even ADLs he has to depend, anxiety and depression, increased risk of exacerbations, and a prognosis is also going to depend on this. Yeah, next. So what is the impact on quality of life? A survey was done of 1100 COPD patients, identified the following symptoms as having the greatest impact on the patient's perceived well-being. He said, madam, the coughing is very bad. Next comes shortness of breath, fatigue, and increased sputum production. So most of them have reported this to impair their quality of life. Yeah, next. So other indicators of poor prognosis, when my patient is losing weight, we always say, 10% in last 6 months or 5% in the last 3 months. So this is the one which I am not happy. See, there are 2 patients on either side when I go for the hospital ward rounds, and I say, this patient is okay, he's on the BMI is better, but this patient I'm more worried. His BMI is very low. So he may have a resting tachycardia, and even on look of him, tachypnea will be there. His work of breathing will be very high. So that means he's having a dynamic hyperinflation and there's nothing which is going in and coming out. Absolutely, it's very difficult actually because he has his FRC is at the highest. So, and when I do a ABG, I know that his oxygen PO2 will be very low. He'll be building on his PCO2. So he may have a type 2 failure and he'll be on continuous oxygen therapy. Yeah, next. This is how you recognize the end stage. Well, I wouldn't say this, but there was this one which I would say, because most of the patients, see, it's not like a cancer or something, but it's almost is equally debilitating, equally distressing like a cancer. Because we have our own patients actually who we are maintaining actually last 5 to 10 years on a reasonably good therapy. But sometimes, you have to look for lung cancers, you have to look for cardiac diseases, and he may succumb to a pulmonary embolism or he may have a sudden cardiac arrest. So pain, commonly as you see in all these chronic lung disease, very distressing is breathlessness, followed by, actually I'll say cough only. Pain is comparatively less, so fatigue is more commoner, and sleep problems. Yeah, next. So, well, this is one of the slides I had picked up actually, wherein again breathlessness has been put at the highest. That is the most distressing symptom for the end stage lung disease patients. Yeah, next. So how do you identify? So it's like, it's very difficult to identify, but there are some signals at least, like, in spite of your optimal management, he's still dyspneic. Even he's dyspneic to leave the home. He has multiple hospital admissions. In this year, I'll calculate in 2022, he was admitted 5 times or 4 times. Increasing number of visits to physician. He takes nebulizer, but no use. He has fear, anxiety, panic attacks. And even attenders, caregivers are stressed out. They say that we increase oxygen, we give all these, but he's still listening. So these are the things which make you identify, yes, he's not doing so well. Yeah, next. So you already know actually we reduce the symptoms and we reduce the risk. For a stable COPD, we have to do these both. We relieve symptoms, we improve the exercise tolerance, we improve health status, and similarly reduce the risk of exacerbations and progression of the disease. So I'm very happy with my COPD patient when he walks down to the OP. I always say, see, last time you were in a wheelchair. Today I'm very happy you have walked down to my OP. Okay, and that itself makes them actually feel very good because yes, even the small thing which we have noted that he is able to walk and they have the willpower to come down because they're feeling so good now. Next. So what are the pharmacological treatments? So we are all aware that bronchodilators is the first treatment. I'll be elaborating a little bit on it. Steroids, whether it's a nebulizer or whether it's MDI or with a rotahilar, what we call is MDI or DPI. So dry powder inhaler or MDI or a nebulizer. Or oxygen, a course of antibiotics. Antifibrotic doesn't come, of course, in this. Morphine or non-invasive ventilation. Yeah, next. So bronchodilators, yeah. For long, you all remember 93, 94, salbutamol had come. The first one, which was came in 92, 93. Then immediately it was followed by salbutamol, levodopa, and terbutaline. Those were the days when they used to give deriphyllin, decadrons, and terbutaline. They all stopped because a lot of tachycardia. We were pushing the patient into ventricular fibrillations. We were having a lot of tachycardia. So when salbutamol came as a nebulized form, it was a really boon in this time because salbutamol, levo, and then came levosalbutamol. Then came long-acting bronchodilator, which we call LABAs. So they are the ones which are salmeterol, formoterol, indacaterol, and now we have got olodaterol. So formoterol is available, formoterol is available in the respule form, which you can use as a nebulizer. And it's a long-acting one, 12-hourly effect. So it is comparatively less amount of tachycardia. And we use very commonly LABA combinations, early onset of action, rapid onset of action. Within 30 minutes, the effect comes and then the patient feels very comfortable. Where salmeterol, little lipophilic. So because of the lipophilic bonding, it takes a little longer as compared to formoterol. So whenever I put my patients on formoterol, they have a quick relief compared to salmeterol. So salmeterol, there were some studies, they said actually that the risk of pneumonia was high, but now other studies have come up, which they have said, no, salmeterol is very safe, especially with cardiac comorbidities. Yeah, next. So now antimuscarinic agents, these are inhaled. We have SAMAs and LAMAs, just like SABA and LABA. So this is short-acting muscarinic antagonist, ipratropium. And long-acting, now we are using only long-acting, tiotropium, glycopyridinium. Even glycopyridinium has come as an inhaled form. So you all are aware that it reduces the secretions. But it causes what? Dryness. It causes constipation. It causes urinary retention. You should not give to your glaucoma patient. You should not give to your benign BPH patient. So I tell, like, you know, if he has glaucoma, if he has BPH, if he has urinary retention, if he has already constipation, be careful. So you can still use, otherwise glycopyridinium is excellent today for all the COPD exacerbations. This is only once daily. There was one go where I used to use ipratropium every 6 hours, but now it's not so. But remember the side effects of it. So when a patient of yours on LAMA complaining of dryness of mouth, look into your drug chart. Yeah, next. Inhale corticosteroid. This is one of the best of the treatment, especially for your bronchial asthma patients. It is one of the best anti-inflammatory, and we are very lucky as pulmonologists that everything is available in inhaled forms. So we have got an excellent combination of LABA and ICS. So long-acting bronchodilator and ICS. Today, various groups are available. Today, we have got 24 hours effect. Vilanterol and fluticasone is available. So these are the ones which we use them. Even sometimes they forget to take the second dose. We say twice daily. Now they have brought once daily. So we are very happy with these drugs. But only thing, please remember, it causes a lot of oral candidiasis, hoarseness of voice. And the patient comes back in the next, ma'am, my voice is altered. I say, you are on inhaled steroids, is bound to happen. So either by counseling, and then maybe we may need to remove for a short while. And you always look for oral candidiasis also. Yeah, next. Methylxanthines for COPD management, gold guidelines, you can put gold guidelines 2022. You will see methylxanthines in one of the steps, maybe in the 4 or 5 steps. But there are a lot of this one going on all around the world, whether doxorubicin should be used, deriphyllin should be used, few say still. But in India, most of us are using, but I think it's not a good, this one compared to the inhalers. Causes a lot of palpitation in your patient. You may have a lot of erythemias also. Yeah, next. So medical management of dyspnea. Now I know actually our palliative team and palliative might be waiting actually. So what is the role of these opioids? See, after a long struggle, pulmonologists have come to believe that yes. Now in the recent, just I attended the state conference of Pulmonology Association, and I was very happy that at the end of the COPD slides, they had said accepted opioids as a treatment for refractory dyspnea. Now your patient is having a refractory dyspnea, you want to give something. So 2.5 milligram, they have said we can start twice daily. You can increase to thrice daily, 8 hourly, or then you can make it to 6 hourly also. So if your patient is already on a pain management, he's having both COPD and lung CA. And then in those cases, you can increase the dose by 50%. Okay, so already he is having. So that's good actually that we have finally accepted the opioids with lot of apprehension. I'll have few slides on how we have accepted. Yeah, please, next. Benzodiazepines. So then they'll say, ma'am, I'm already on, my patient is already on morphine. Should I use? Yes. He'll have panic, he'll have anxiety disorder. That is the reason of his insomnia. No harm in using a small dose of lorazepam. Maybe start with 0.5 and you can increase to 2.5 or a diazepam. Sometimes you can give a sublingual also in those panic attack because you have to calm him down. Because panic attack will lead to increased work of breathing. And this will retain more PCO2. And then he'll land up on NIV. And then he may get intubated. So it's like a vicious cycle which will follow. So the first and the foremost, you have to reduce his panic, anxiety. So that is the reason actually that the primary physician whom he is very comfortable with comes and stands beside and puts an arm around. That's more than enough actually. First, it will reduce his panic and then you can go ahead with the further treatment. Yeah, next. So yeah, oxygen, most of these patients will finally have a respiratory failure wherein type 1 failure is only oxygen goes down and type 2 failure is when the carbon dioxide is going to raise. So most of the patient first initially type 1 failure, you have to use oxygen. So we have got now a clear prescription of LTOT. So we have every doctor, especially pulmonologists, are giving a prescription of oxygen now. How long, how many liters, by what device you have to take, how long you need to keep. And saturation should be anywhere between 92 to 94. Don't improve to 98 because that is a drive which is actually making him breathe normally. Parental medication, if he is not able to take oral, you can still go for parental. Yeah, next. What are the non-pharmaceutical? Definitely, as I already told, calm. See, healthcare team should be quiet. It should be able to relieve his anxiety. Anxiety itself, as I told, it will lead to a vicious cycle. So you will ask him to calm down. You can lose the patient's clothes a little bit. No need to wear a tight. Put a table fan. I always say, increase the fan. If it's in 2, you make it 5. Let him get open the windows. Let him get more breath. Comfortable positioning. Put a arm this one, or you can keep a table in front so that he leans forward. Allow him to have a personally breathing. Sometimes if he likes some music, put on some music. Okay, next. So counseling, you have already counseled them, but you can be and reassure some relaxation postures, step-by-step instructions. Rehabilitation helps quite a lot. And ma'am, Raja, my IS ma'am's slides, I have picked up one again. This is guided imagery is designed to impact the body as well as the mind. And ma'am will be able to tell better, and breathing typically becomes slower and more controlled during the process while muscles relax and creating a state of calm and relaxation. So this could be done by some music and other therapies. So means you take his mental balance into some state of mind wherein which he likes most. So just imagine that visually in front of him, like the best place when he visited. So it's very difficult. It's easy to say, but it's hard to practice. But over the times, maybe he has to do that. So it will calm him down. Yeah, next. So physiotherapy management, of course, we have got many of the centers have got good physiotherapists who are also a part of our team, occupational therapists who help our patient actually for diaphragmatic breathing. In fact, now with these COVID times, we have got these online videos and online coaching for the physiotherapy. So that will help them in positioning, secretion clearance, and they are also able to. Only drawback is we have to monitor the oxygen saturation, that it doesn't desaturate during such exercises. So 1 or 2 hospital visits are needed, and then maybe home rehabilitation he can continue. Yeah, next. So supporting the coping, see the role of caretakers is also very important. So one of you will have to say that caretaker group, all of them should not leave together. One of them should be beside the patient. Say, don't worry, I'm always with you. Whole of the night we are around only. So that helps him to relieve the anxiety immediately. And the look of him, the way, the empathy is the one which is going to play a great role in all these during these exacerbation episodes. Yeah, next. So a little bit on the cough also, because wet cough, sometimes you can use some nebulized saline and mucolytics. I don't use much of it, but mucolytics, yes. NAC has come, N-acetylcysteine. Now they have combined with vitamin C. Some people are combining with lactoferrin also. They are saying it's more of a mucolytic and also antioxidant. You can give as an effervescent. It's an effervescent tablet which is available, and it can be put with 200 ml water, and you can give. That's a good mucolytic sort, and also has got an antioxidant. And a dry cough, yes, you have got lot of actions. You have got benzoate, which is peripherally acting. Centrally acting, of course, once you give morphine, it will have a dual role. But otherwise, you can use some of your opioids and codeine, of course, and dextromethorphan. So these are some of the suppressants that you can use for your COPD patients. Yeah, next. So let us have this case scenario because I want to break the monotony of this one. We have got an 81-year-old male, Mr. Rao. He's a known case of COPD. At 80 years itself, he has got, what are the comorbidities you see? He has hypertension, he has depression, he has heart failure. He is a known case of CAD, diabetes, hyperlipidemia, and glaucoma. So the look of it itself, you know that what are the medications he'll be on. COPD was diagnosed 10 years ago when the spirometry showed a FEV1 of 63%. He was on home oxygen last 3 years on 2 liters per minute. His regular medications are, he is using salbutamol every 6 hours as and when needed. He's on formoterol also and mometazone also. So formoterol is LABA, as I told you. Mometazone is ICS, inhaled corticosteroids. Yeah, next. So see the list of the medications. This is what is known as polypharmacy in geriatrics. So he's on aspirin, he's on lisinopril, he's on metformin twice daily, he's on simvastatin, he's on omeprazole, calcium supplements, sertraline for his depression, mitas, triazolam for his insomnia. Sometimes he takes acetaminophen for his pain, and he also has his eye drops for his glaucoma problem. So this is what is his various prescriptions. On examination, his BP is 170/80, no temperature, and he's experiencing moderate respiratory distress and bilateral expiratory wheeze, the poor air movement with bilateral expiratory wheeze. And chest, cardiac wise, he is normal. We do a GDS always. Geriatric depression score is positive, which is 9/15. And we do also MMSC, which lets us know his cognitive function, which is 29/30. Yeah, next. So what are the things? Now, I am a pulmonologist. I will do only one thing. I will say, yeah, he is having COPD. So he must be exacerbation. And it's a heart failure because he's having LVD. He's a cardiac case. He must be having heart failure exacerbation. So it must be medication related because it is from polypharmacy. He must be having respiratory muscle weakness also. In addition, he is having osteoporosis, which could be further worsened by kypho. So this is what are the various things which come into the mind when he comes to the EMD, emergency department. Next slide. Advanced age also may lead to sarcopenia, muscle weakness, anemia. He may have postural hypotension because of this, various interaction of the drugs, low cardiac output, and also balance impairment because of both antidepressants and opioids. What about the social issues? He may be having anxiety, depression, pain, social isolation. He may be experiencing sleep problems. So this is the role. Now, a doctor, a normal physician will only treat the first half. Now, what about the other half wherein we have to plan a nice palliative care and advanced care directives? Next. So living with advanced COPD is not just treating his breathlessness, cough, and respiratory failure, but you also have to account for his anxiety, social isolation, hopelessness, actually, which comes along with this advanced lung diseases and frailty. Yeah, next. So management in the last few days of life. See, you have to prepare the patient and the attenders both. So many a times I see now the stage has come wherein he is retaining CO2. We have moved on from oxygen to BiPAP. So that is a stage wherein I tell that whatever we are doing, his lungs are not responding much. So with various additional things, only we are able to maintain him, and any exacerbation can worsen his situation and he may succumb. So how do you want to go about it? In the sense, would it be at home, or would you like to admit, or should I intubate him in ICU, or would you not? Just non-invasive ventilation is enough. So I think it's we should assess our patient at the right time. And every visit I have to count, I make it a point to discuss with the caregivers that next exacerbation may be almost life-threatening. So how to go about it? Let's have a plan. So this has to be done actually. I think most of the physicians should be able to assess your patient and do accordingly. Yeah, next. So as I already told, it's just this one. I'm sure actually by now most of you must be aware of all these things. Next. So this, this has to be done with the team. So it's very difficult. Primary physician is the main person. The moment I call a palliative care team, I introduce them along with, I'll be there to introduce, because I'll say I'm there with them. We together are going to manage you. So patient is bedbound, he's semi-conscious, patient is no longer able to take tablets. He's able to take only sips of liquid. So many a times attenders call up on the phone and tell, ma'am, he's going very bad. He's not able to, just he's bedbound. He's not taking anything at all. Now what to do? Okay, he's not responding to commands. So then that is a stage that it should be like, it should not be a shock for them. They should accept it, including the patient as well as the attenders. So we have given them a complete picture, and we have also addressed their concerns and the doubts. Yeah, next. Sometimes there will be terminal respiratory secretions. You all are aware that the death rattle, sometimes you feel that they are actually here. And then sometimes you may have to reposition the patient. You will say, many of the people just go on putting IV fluids. Don't hydrate the patient. He's already having a LVD. He's already having cor pulmonale. So it's going to worsen the situation. And you also have to address the family distress. And drugs can also reduce the death rattle. Like, I'll tell you what are those drugs. Yeah, next. Sometimes you have used a glycopyrrolate, but now I think with this nebulization form, it's a better way actually, wherein we can reduce some secretions. And also ipratropium used to be used, but maybe our palliative care team will be able to better throw light whether we are still using actually the atropine and all that. And still, I think atropine is recommended, because see, palliative is such a thing that where you have to give some comfort to the patient, especially at the end of the life. Yeah, next. So what are the other measures? Yeah, some treatable causes, of course, you should never give away to your patient. You should be able to, because diuretics reverse immediately the failure part in the LVD. And after 2 days, you see that his hypoxia has improved and he has become, actually tachypnea has come down. Antibiotics, of course, all the infection gets cleared and it becomes back to the normal again. So we see multiple times. So we just tell that we'll just wait for 24 to 48 hours, whether it's going to go the other side or this side. Many a times we have seen that 70% are baking it and they come out of it to the ward, and the family members are happy, we are also happy. But the other way also they are accepted. So yeah, next. So, well, checklist, I won't say, but well, checklist is, let us assess the medications. Let us not prescribe some parenteral medications or subcutaneous like analgesia, antiemetics, some sedative, LAMAs and all. Consider commencing a syringe driver if needed. And you just ask your sister to monitor closely. And maybe need not do too much of blood tests, because you know that the CO2 is retaining. The patient attendants are not willing for any intubation, and we don't know whether if once intubated he'll make it or not. So let us avoid certain things actually regarding. And often we in our hospital we take DNR and DNA consent forms. Yeah, next. So regarding morphine, as I told you, actually, myths and mechanisms. So many of the patients, especially our own doctors, used to say, ma'am, if we give morphine, will it not to worsen the respiratory depression? Will it not worsen the hypoxia? So no, it's not going to. No respiratory depression. Start with low dose, monitor closely. At what optimal dose he's feeling very comfortable, you can continue with that. Yeah, next. So it's a wonder drug, actually, I can say, because meta-analysis has showed that high statistically significant positive effects are seen in sensation of breathlessness. Multiple papers are there for that. Greater effect have shown by oral and parenteral opioids, and no nebulized opioids. So no need to give any nebulized, and no instance has been reported wherein PaCO2 has risen, increased at all, or PaO2 has fallen because of opioids. Next. So these are various actually studies which have been done in population, and you have seen the various primary and secondary outcomes, how they have compared. Primary outcomes regarding CAT score and PaCO2 level, and secondary outcomes regarding the hypoxia, saturation, the respiratory rate, and also overnight saturation. So these all they have shown negatives. Like morphine has not affected in any way in all these actually outcomes, and in fact it has shown much improvement. Yeah, next. So morphine, both subcutaneous and IV. So to break the cycle, usually what we start is 2.5 mg. My palliative team will be correcting me if I'm wrong, but what we are doing is maybe twice daily, and then slowly I may increase to thrice daily and observe, monitor. So that is the optimal level. He feels very good. I'll maintain at that stage. In case of end-stage diseases and he's able to, then maybe we can increase further to 6 hourly. So nebulized opioids, no, not recommended. Yeah, next. Terminal breathlessness, we all know actually this. You can combine both morphine and midazolam. Sometimes in morphine naive patients, you can give 10 mg and with 10 mg of midas also. And slowly you can increase the dose actually of opioids further. Because see, it's so distressing. Like, I tell my patients, caregivers especially, they don't know what breathlessness is, how difficult it is. So I say, have you seen a straw? You take a coconut water or a cold drink with a straw, right? So what is this one of the straw? So his tubes have narrowed to the straw level. So just imagine you pinch your nose and you breathe through the straw. How much air goes in? That is how your patient is suffering. So, if anyone does that, you know what it is to feel breathless. So supposing actually there may be some people who would have had asthma or who may be asthmatic, so they know what it is. But there are many patients who can't perceive. They look at their patient, why he's suffering so much. So this is how. So to get exactly that feeling, so few of the physiotherapists, in fact, there are role play and this one, wherein the physiotherapists do this to experience what exactly the patient is experiencing of a COPD patient. Yeah, next. So this is again actually taken from this one. See, this is a vicious cycle which follows. You have this breathing difficulty, you have respiratory rate is increasing, you have axillary muscles, you have dynamic hyperinflation. Your work of breathing is very high, it causes breathlessness. This breathlessness, you can sense the depression in the patient's eyes. You have eye-to-eye contact, you see. He just looks in your eyes and he says, am I going to die, doctor? He need not spell out. You can understand that. And he has a lot of misconceptions and he'll be having the thoughts about dying. This causes further anxiety, distress, and feeling of panic. It leads to further breathlessness. This itself is going to reduce his activity, deconditioning. He'll just sit at one place. He can't move because he knows any movement will further worsen his breathlessness. And again, that will create panic. And again, that will lead to further breathlessness. So it's like a vicious cycle. And he's just bedbound. And even minimal activities like eating also he avoids because even eating might worsen his breathlessness. Yeah, next. So I think I have tried to actually bring together both advanced lung diseases, treatment management, pharmacological, non-pharmacological, role of palliative care and advanced care directives. And to conclude, I'll say that patients with COPD hospitalized with an exacerbation are confronted with a life-threatening illness and severe symptom burden. So need of palliative care to be integrated with respiratory care. And it's a multidisciplinary approach. So it's always a teamwork with your physiotherapist, with your primary physician, of course, with your palliative care team, with your nurse, with your occupational therapist, physiotherapist. Maybe even if you don't have all of them, you may have to do a multiple roles. And we are very happy that most of us have done some, course of these palliative care, and we have understood the significance of it, especially to manage our chronic diseases patients. Admission for COPD trigger point to initiate palliative care. The biggest question actually is when, as early as possible, because it's not a reversible disease. Any time it's going to actually land up in problems, and any exacerbation can be detrimental to his health, and it may be life-threatening. So why not early? Why not introduce him early? And also advanced care directives, you will need to discuss with the attenders. Don't keep it to the last. Don't come out of your ICU and say, I'm sorry, he's become very bad. So he'll just, ma'am, never you have given us any idea that our patient is going to worsen. And palliative treatment for breathlessness. So please remember all this. Yeah, thanks. Yeah, thank you. Thank you for your patient listening. I hope I was able to do justice for this topic. And I think I'll await the comments from my mentors or seniors, Sridevi ma'am and Rajam ma'am. Please. Thank you.
Thank you. Nobody is a senior or everybody is on the learning curve. Thank you, Dr.
Okay,
Anupama.
ma'am.
But I request the participants to please ask questions of the practical aspects they see, because they're all doctors who are trained in palliative care. And the whole purpose of this sessions was to train them to become more confident in looking after patients of COPD and asthma when they do home care visits or when they come to their palliative care OPDs. So if you have any questions about what issues you all face on a day-to-day basis, please go ahead and ask Dr. Anupama. In a nutshell, and to summarize, the basic concept of having this talk was to help you differentiate between COPD and asthma, both being airway diseases. Most important is how to, you sometimes see patients, the treatment for both of them is, in the initial time is not the same. By the time probably the palliative care physicians see both these patients end up in the similar inhaler therapy. But you need to understand that the basic pathophysiology of asthma is genetic, wherein these patients have childhood symptoms, they can have family history, they can have other allergic symptoms like skin, nose, eyes, etc. And the hallmark is the reversibility in the lung function test. Because asthma comes episodic, these patients have normal or no symptoms in between episodes. And these episodes could last either once a year, once in 2 months, that's irrespective. But the difference in COPD is that it normally is seen in adults. It is due to smoking or other now recognized other pollutants. And most importantly, this is a condition which gradually worsens and progresses. So patient has symptoms every single day of his life. So pathophysiology is different despite the fact that it is both airway diseases. So history taking, examination, and what you see is going to help you diagnose this with the help of lung function test. A lung function test is extremely important in differentiating the two. And we will have a separate session on PFT and how to interpret PFT and the nuances of arterial blood gas also. So please do post questions. Yeah, there's a question from Dr. Subhashini. What can be done when patients have tremors due to short acting and long acting bronchodilators?
See, Dr. Subhashi, the most important thing is we have to relieve his breathlessness first, right? So reassurance is the most important thing. So most of these actually last for a brief while and then they become okay. So that is not a reason actually to interrupt these drugs, because these are very important drugs, especially LABAs cause very less tremors as compared to SABAs. And of course, for his primary problem, you need to give them.
I would just like to add by saying that when you take it as an inhaler, so for example, my MD teacher used to actually tell us to try to take one small dose of oral salbutamol and see how horrible you feel. But inhaler medications thankfully do not have so much.
Much.
And when you
Yes.
are prescribing inhalers, the most important thing to do is the technique. You cannot prescribe inhalers and say, go home and take this, because they're definitely going to do it wrong. So we actually group patients. That's what we used to do in public hospitals. All those patients who have been newly prescribed inhalers, we used to group them and teach them how to take the inhaler. And also the method of using the meter dose inhaler has to be through a spacer. It cannot be directly, like we see very often people taking it in the mouth. It's the worst way of taking inhalers. So when you give inhalers, the doses are in micrograms. Does not cause so much tremors, but please always check your technique of the inhaler. It should not just be taken. And sometimes what happens also is when the patient is anxious, he overdoes the inhaler or he keeps taking nebulizer. So we need to break that, explain to it, explore anxiety, explore the fears and why he is taking so many times, because that can cause tremors. Normal regulated dose of inhalers does not cause as much as oral drugs. So Dr. Rajeshri has said about codeine and Tossex and says that I prefer to use morphine for breathlessness. I agree with that, madam, but sometimes for cough, a low dose codeine helps. So you want to add to that, Dr. Anupama?
Yeah, because those were the days when it was used only for hemoptysis initially, because we had mid and codeine. But now also it is available actually in few of the states. In our state, actually it's available. And by doctor's prescription, they are giving actually codeine linctors. I mean, in few of the states, maybe I think Kerala and all, it's not available. That's what I'm saying. But we can use, yes, definitely actually. Codeine is a good alternative for suppressing the cough.
Yeah, Dr. Rajesh is also saying morphine can be used safely. Very true. And it need
Yeah.
not be refractory. That's also true. But what I think sometimes, madam, what we also face is that patients are happy to try the syrup to get alleviation of symptoms and trying morphine. So it's just a one step before to relieve them of their comforts. For those people who do not have access to morphine, well, in the West, they have other medications like I know if you don't have morphine, probably you don't have other medications also of morphine. but maybe in Oman, they might have a buvelo patch. Having said that, I'm not so sure. Maybe Sridevi or somebody from Pallium India can help me. I'm not sure of the palliative care uh, thought process and approach in UAE. You have to highlight us to that. Um, that is very important because you need to know the rule of law of the land before you start prescribing, because we have seen many patients with UAE who do not have access to palliative care that easily. So regarding morphine in UAE, I don't think there's any substitute for morphine. Dr. Rajeshri
No.
or Dr. Sridevi, would you want to add to that?
Yeah, the same thing. When he said Oman, I was thinking there are many Gulf countries where palliative care and morphine is available, but I'm not sure about Oman. But I was just texting him to write to us about the location. It's worth a try. If there is nothing, then we need to start working on something. So I'll just try to see what is the law, whether we know something about it, whether we have someone to refer to. So
There's another question, Dr. Anupama. What are the
Yes.
indicators for IV bronchodilators and steroids?
See, I would like to say that during an acute exacerbation of a chronic obstructive pulmonary disease or bronchial asthma, we definitely use IV steroids, because those are the time. Not that oral steroids also can be given, like prednisolone, methylprednisolone, but if the patient is very sick, his work of breathing is very high, so those are the times wherein you can give IV steroids. And we are using both methylprednisolone as well as hydrocortisone. Also is used in few of the places. But steroids, yes, definitely they have a role, IV. And as per the recommendations today of both the GINA and the GOLD 2022, 5 to 7 days of steroids during an acute exacerbation is mandated. And that can be given either as IV, or if your patient doesn't want to get hospitalized and he's okay, he's able to take his oral intake, you can start with the oral steroids. Now, another one is IV bronchodilators, no role now after the nebulized drugs have come. Absolutely, because it's very difficult to know the therapeutic index for these theophylline. So, and it causes a lot of adverse reactions. So, no way. Nebulized drugs are the best form. And we have got very good bronchodilators. Long acting will also come bronchodilator like aformoterol and others. And we have got levosalbutamol that can be given every 3 hourly. In fact, back to back also is given during an acute exacerbation. Every 20 minutes you can give, and even and you can observe for tachycardia and other side effects. So I think after the nebulized bronchodilators, nobody is using the IV bronchodilators, and we don't even recommend now IV derifilin and others without any monitoring.
Yeah,
I
because the
think,
threshold
yeah,
of IV bronchodilators to cause
yes,
cardiac side effects is with the therapeutic index is very, the window is very narrow,
very,
where the
very
bronchodilator effect is optimum and the cardiac side effects start. So as it is, these patients, especially elderly and COPD, may already have cardiac compromise. So it's quite dangerous to use IV bronchodilators. Another question for you from Sheila is, most COPD patients are not comfortable with inhaler. Can we give them some medication through nebulizer and respules form? The
see,
same medication. Sorry,
yeah.
can we give them the same medication? Yeah.
Same medications, yeah. See, for COPD patients, the basic problem comes with the breath holding. See, most of these inhalers, meter dose inhalers, the spacer which they use, they say that the patient has to exhale completely, and then you take the medicine, inhale, and hold the breath for 8 to 10 seconds, which is very difficult for COPD patients. So many a time we have seen that the deposition of the medicine occurs more on the oropharynx. So this is the reason that they come out actually with oral ulcers. So, and then actually elderly, as you know, they'll have some amount of arthritis, and this hand to mouth coordination is also very difficult. And they have to depend on a caretaker. Sometimes, even if you explain, they'll go home and do the wrong thing because of cognitive issues and remembrances. And sometimes they may have visual problems and hearing problems. We think that they have heard, but they would not have. And even so, these are all the various things. So in those cases, I finally actually we have to go to the nebulizer form, because sometimes somehow we have to make the medicine to really go in. And nebulizer form, what respules are available in COPD? We have got a long-acting bronchodilator is available now today. We have got a LAMA, long-acting muscarinic antagonist like glycopyrrolate available. We had ipratropium, and we also have now, which is also used every 6 hourly. And so these two are more than enough actually, because many a times we say to the patient, and even inhaled corticosteroids are available as nebulized form. So we have got a LABA and a ICS combination. We can give twice daily, and we can give once daily Alama. So three nebulizations in a day will help him, and in between he can take a levosalbutamol if needed. So by the same budamate which comes, which is formoterol and inhaled corticosteroid, is available as a Respule, and glycopyrrolate, which is available as an inhaler, is available as a Respule. Yes, so you can give. Yeah.
Can we get some from Dr. Subhashini? Can we get a table with dosages for different groups and mode of delivery? So, Dr. Subhashini, I have sent you some links of the COPD gold criteria 2022 and the GINA guidelines for asthma criteria, where everything is described depending on which category the patients are. That means which severity, as a step ladder form. So where you add what, I have already shared it with you in the chat. So if you go ahead, you can copy paste it and get all the details. You have pocket guides, which you can actually keep it in your pocket. Any further questions or doubts or clinical scenarios or thoughts, please do share. Oxygen cylinders are expensive for certain people who are on regular oxygen in home care. Takes a toll on finances. I have seen a family planning to sell their house for oxygen cylinders. So Dr. Navi shall definitely tell Dr. Anupama to add. These days we have oxygen concentrators. They are not cheap, but they are available on rental. They are available second hand and they're available fresh. These are machines which convert atmospheric atmospheric air and release the nitrogen and only supply oxygen to the patient. They come at the size of a suitcase, not a cabin case, but they can be used with long tubes so that the patient can walk around the house. The problem also with oxygen cylinders is the difficulty with which you refill, etc. So if patient is on the second floor, no lift, it's a dilemma. But this oxygen concentrator requires electricity. So places where the electricity keeps going off, you need to have a standby oxygen cylinder. Anything else you would like to add, Dr. Anupama?
Yeah, ma'am, very true. I agree with this actually. But oxygen concentrators also are costing, like in the
Yes.
sense, 4,000 to 5,000 is a rent actually per month. And somewhere between 55,000, 45 to 65,000, anywhere in between, depending on this. So if they want to purchase it.
The other
So,
issue,
I
Dr.
mean, one or two companies I have initiated to give on EMI.
Yeah.
Because I have forced them literally actually to give a EMI. And because I have taken the risk of my patients and said you can pay monthly. Instead of, monthly paying 5,000, you give him a EMI. So it's very difficult. Yes, true. For the lower socioeconomic, it's a real. But there are some NGOs here and also some associations who have come forward and they are giving for 100 rupees per day.
But
So that's
Dr.
quite a
Navish, what is the choice for a person who has got advanced lung disease and who requires oxygen? Hospitalization is going to be much more worse. And LTOT has clearly shown the way that it not only decreases hospitalization, the patient remains with less exacerbations and can continue to remain at home with a decent quality of life. So you need to weigh the benefits and risks of, not giving oxygen, and admitting the patient for oxygen is going to be really very expensive. Any word on pneumococcal vaccine and flu vaccine? Is it mandatory? Ideal time to give flu. So Sheila, all people, it's irrespective of the diagnosis of a lung disease, all people above the age of 65 should be given annual flu vaccine. Typically in India, at the end of August and beginning of September is the time to give flu vaccine. Pneumococcal vaccine, you should give above the age of 65 once in a lifetime. That includes both pneumonia 23 and Prevenar 13. But please do remember, it is a part of adult vaccination program. It has nothing to do with lung diagnosis. Yes, in patients with lung diagnosis, they actually probably merit to get it even earlier. So anything else, Dr. Anupama?
Yeah, because of the rise of H1N1 cases and swine flu cases, definitely actually even for the younger people, sometimes with bronchial asthma and all, we are preferring to give a flu vaccine during those days. Because, so this is a time actually where the new one comes into this. And we give it around early week of September. So now the new one has come. So every yearly once. So that will take care of this H1N1 and other viral infections also.
And other thing that can be added to this list is zoster vaccinations. Elderly people are prone to getting zoster and it can be extremely debilitating. So you can prevent zoster by giving herpes zoster vaccine.
Yeah. One
Those
more
people-
point, ma'am.
Yeah.
Tdap has also come now.
Yeah.
The tetanus and the diphtheria. Yeah, Tdap vaccine. So in the elderly, actually now the guidelines of COPD also have recommended that in addition to earlier it was only pneumonia vaccine and influenza. Now we have got the Tdap vaccine also, which is to be administered for COPD patients.
So we need to make awareness of adult vaccination, because lot of adult deaths are due to avoidable bacterial infections like pneumonia or flu, and it can be really debilitating for the elders who recover from these infections. Any more questions
I
or
think we
thoughts?
have the questions from the chat, but if there is any question from someone who wants to unmute and
Or
ask.
share or the experience of looking after a patient or something like that, please let us know. It's nearly time, and we did start late, so we don't want to keep you late. But over to you, Rajalakshmi, for the concluding this thing. Yeah, great.
Yeah, she has sent the